All right, welcome. If you've got your final exams on the horizon, or you just need a really solid high-yield refresher on a core ICU topic, you are in the right place. This is your masterclass on Continuous Renal Replacement Therapy, or CRRT. Let's dive in.
So let's start with a scenario that is all too real. Your patient in the ICU is already in shock, and now, on top of everything else, their kidneys are starting to fail. The pressure is on. What's your next move? Knowing how to answer this isn't just for exams. It's absolutely fundamental to critical care.
So here's how we're going to break it all down today. First, we'll look at the problem itself, acute kidney injury. Then the solution, renal replacement. We'll get into the physics of how it works, look at the different modalities you can choose from, cover the practical day-to-day management, and finally, we'll talk about the risks and what can go wrong.
Okay, section 1. Let's start with the big why. Why is acute kidney injury, or AKI, such a massive topic and a huge deal in the intensive care unit?
Well, the answer is simple. It's everywhere. Just look at that number. Up to 60% of patients admitted to the ICU will develop some form of AKI. And it gets even more serious. Of that group, almost 2/3 might end up needing some kind of renal replacement therapy. So this isn't some niche topic. It's a cornerstone of what we do.
So what exactly are we talking about? Well, AKI is basically a sudden and rapid drop in kidney function, something that happens over just hours or a few days. And this isn't just about a lab value going up. It means the kidneys can't do their job. They can't filter waste, they can't balance fluids, and that can become life-threatening really, really quickly.
Okay, for your exams, you absolutely have to know how we diagnose this. The global standard is the KDIGO criteria. And the great thing is you only need one of these 3 things to make the diagnosis. Either a small but significant absolute jump in creatinine, a 50% rise from their baseline creatinine, or a really worrying drop in urine output. Know these 3 cold.
So your patient officially has severe AKI. Now what? What can we actually do about it? Well, this is where renal replacement therapy, or RRT, comes into the picture. It's essentially an artificial kidney that supports the patient while their own kidneys are offline.
Now, the decision to actually start RRT isn't taken lightly. It's usually triggered by a life-threatening emergency. This is one of those classic exam lists you've just got to memorize. The patient is drowning in fluid, their potassium is dangerously high, they're confused from the buildup of toxins, or their blood is severely acidic. And sometimes we use it for specific poisonings, too.
But here's where it gets a little more complex. While those emergency indications are pretty clear-cut, the timing of when to start for a patient who is not an immediate crisis, well, that's a huge point of debate. And this is a key trial to know, the START AKI trial. It basically showed that jumping in and starting RRT early didn't actually save more lives than a more conservative watch-and-wait approach. This tells us that starting RRT is a really nuanced clinical decision.
Okay, let's switch gears and get into the nitty-gritty. How does this amazing technology actually work? How do you take a person's blood, run it through a machine, and clean it? Well, it all boils down to 2 really fundamental principles of physics. And this slide is absolute gold. It shows you everything you need to know. At the top, you've got convection. The best way to think about this is like making coffee. You apply pressure, water is forced through a filter, and it just drags the solutes, the waste products, along with it. This is really effective for clearing out bigger, medium-sized molecules. Then at the bottom, we have diffusion. This is simple chemistry. Solutes naturally move from an area of high concentration, which is the patient's blood, to an area of low concentration, which is a special fluid called dialysate. This works brilliantly for small molecules like urea.
Now, once you understand convection and diffusion, you're pretty much there, because all the different types of CRT we're about to talk about are just different recipes using those 2 key ingredients. So let's take a quick tour of your options.
First up, we've got CVHH. The H is for haemofiltration. This mode is pure convection. As you can see in the diagram, we're pulling a large amount of water and waste out of the blood using pressure. But because we're taking so much fluid out, we have to give a sterile replacement fluid back to the patient to keep their volume stable.
Next on the tour is CVVHD. Here, the HD stands for hemodialysis. This one relies entirely on diffusion. We run that special dilate fluid on the other side of the filter, creating a powerful concentration gradient that just sucks the small waste products like urea and creatinine right out of the blood.
So what if you want the best of both worlds? Well, that's exactly what CVHDF is, hemodiafiltration. You can probably guess from the name and the diagram this is a hybrid mode. It uses both convection and diffusion,
meaning we're using both replacement fluid and dialysate to clear a whole range of different size molecules really efficiently.
And finally, there's scuff. You can think of this as the simplest, most basic mode. Its main job, really its only job, is to remove fluid. We use this for patients who are severely fluid overloaded, maybe from heart failure, but who don't have major problems with electrolytes or waste products. It's just very slow, very gentle fluid removal.
Okay, this table is perfect for your last-minute revision. Seriously, this is a great one to screenshot. CVVH is convection, needs replacement fluid. CVVH is diffusion, no replacement fluid. And CVVH-DF uses both and needs replacement fluid. Nail this table down and you're golden.
All right, theory's done. Now for the really practical stuff. We've decided on a modality. How do we actually prescribe this and get the circuit up and running for our patient?
First things first, you can't do anything without good vascular access. We need a special large-bore catheter. The KDIGO guidelines actually give us a preferred order of sites. The number one choice is the right internal jugular vein, mainly because it offers a nice straight shot to the heart, which gives us the best blood flows. The subclavian vein is dead last because of the high risk of causing stenosis, which can be a real problem down the road.
Now, a huge problem with this whole setup is that blood really wants to clot in the plastic tubing of the circuit. We have to prevent that with anticoagulation. We can do it systemically with something like heparin, which thins the blood in the whole patient. Or we can do it regionally, using citrate, which only anticoagulates the blood inside the machine. And this is a really key take-home point. Regional citrate is now the first-line recommendation because it dramatically reduces the patient's bleeding risk.
But, and this is a really big but, if you're going to use citrate, you have to be absolutely on top of the monitoring. Citrate works by binding up calcium, so you have to constantly check the calcium level in the circuit to make sure the anticoagulation is working, and you have to check the patient's calcium level to make sure they're not becoming dangerously low. This is not optional, it's critical for patient safety.
All right, last major section here. As you know, no therapy this powerful and this invasive comes without risks. So let's quickly run through the main complications you need to be aware of.
The problems really fall into a few big buckets. You can have issues related to the catheter itself, like bleeding or infection. You can have problems with the circuit, like the patient getting cold or, God forbid, an air embolism. There are blood-related issues, like bleeding from the anticoagulation. And finally, there are very specific metabolic problems related to citrate, like hypocalcemia. And that really brings us to our final and maybe most important thought. CRRT is an incredible life support technology. It can bridge a patient through a time when their kidneys have completely given up. But it's crucial to remember that it doesn't fix the kidneys. It's just a support system. So the real question, the one that drives all the research in this field, is how do we use this therapy to best create an environment where the patient's own kidneys can recover and heal? And that's a wrap. Everything in this masterclass was drawn from the fantastic anesthesiology tutorial of the week on continuous renal replacement therapy. Thanks so much for sticking with me through all of that, and seriously, good luck with those exams. You've got this.